We've got another great issue this month of Diabetes Core Update. I'm Dr. Neil Skolnick, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. And joining me, as always, is my co-host.
And I'm John Russell, Clinical Professor of Family and Community Medicine, also at Thomas Jefferson University, the Sidney Kimmel Medical School. It's great to be with you tonight, Neil.
John, we really have another great edition, beginning with an article from the New England Journal of Medicine, a placebo-controlled trial of the oral PCSK9 inhibitor, Enlicitide. This is going to be potentially a big deal, going to be a very interesting article. Then, an article from Diabetes CARE estimated optimal individualized diabetes risk prediction from preventive interventions in the U.S. general population, followed by a discussion of another article from Diabetes CARE on the impact of bariatric surgery on weight loss and glycemic control in adults with type 1 diabetes. Then another article from the New England Journal on Finerenone and type 1 diabetes and chronic kidney disease. And finally, from Diabetes CARE, the effect of SGLT2 use on mortality, amputation, and healing in patients with diabetic foot ulcers. John will jump right in to the article from the New England Journal, and that is a placebo-controlled trial of the oral PCSK9 inhibitor Enlicitide. Enlicitide is an oral PCSK9 inhibitor that has been shown in phase 2 trials to reduce LDL cholesterol level, and therefore they then did this much larger multinational double-blind randomized placebo-controlled phase 3 trial that enrolled adults with a history of major ASCVD disease, that would be MI, stroke, peripheral vascular disease, with an LDL cholesterol level of 55 or higher, and individuals who were at risk for a first ASCVD event with an LDL cholesterol level of 70 or higher, people who had, for instance, diabetes and risk factors. Participants were assigned in a 2-to-1 ratio to receive Enlicitide at a dose of 20 milligrams or placebo daily for 52 weeks. The primary endpoint was the mean percent change in LDL cholesterol level from baseline to week 24. Key secondary endpoints were the mean percent change in LDL cholesterol at week 52 and the mean percent change in levels of non-HDL lipoproteins, apoprotein B, and the percent change in lipoprotein A at week 24. There were over 2,900 participants. Mean age was 63. Approximately 40% were women. Mean LDL at baseline entry was 96. The mean percent change in LDL cholesterol levels at week 24 was negative 57% with Enlicitide and 3% increase with placebo. This was a p-value of less than 0.001. The mean percent change in LDL cholesterol level at week 52, the percent change in non-HDL cholesterol and ApoB levels at week 24, as well as Lipo-A, were all significantly better with Enlicitide than with placebo, p-values being less than 0.001, and specifically Apo-A decreased 28%. John?
So, Neil, pretty interesting article. And first, kind of starting with this study. So this study probably looked at the population we'd want it to look at. So 90-some% of the people were on a high or mid-potency statin. So, this wouldn't be in substitution for people being on a statin. And certainly we would want to start people on a statin. So it's a population we care about. It's probably the appropriate population that we would use this medicine on. And this medicine showed that it decreased LDL by 57%. So pretty strong, really very good at getting people's LDLs down to lower levels. Now, the caveats is it showed that it lowered LDL, but it did not show mortality benefit. We've certainly seen that with the PCSK9 injectable medications that we've had, and maybe it won't happen, but I'm going to assume that that does happen. I think the interesting thing for this is going to be kind of what's its price point. So 70% of the people in the United States are not at an LDL goal we would like them to be at. And there's probably lots of reasons for that. When you go back a couple incantations ago of LDL guidelines, high-risk people were 70, medium-risk people were 100, low-risk people might be 130. So you and I in practice at least could kind of say we're putting you in category A, B, or C, and this is where your LDL goal should be. And they kind of changed it generically to you should be on a high potency or a mid to high potency statin, and kind of threw up their hands. And then all these other medicines showed up. So I think that that's going to be interesting things, and why those 70% of people, injectable PCSK9s can range in that $500 a month to $1,200 a month range. It's a lot of money, and a lot of people have donut holes, have a lot of reasons that they can't afford something, even if they have insurance. I think doctors are kind of scared off on prior authorizations, and it's certainly easier to get, the injectable PCSK9s than it once was. But I think for a lot of people, prior authorization is the dirtiest word out there. So I think one of the interesting things is what's going to be the price point of these medicines. If they do have mortality benefit, if they do have a 55% reduction, how much is this going to cost our patients, and what's going to be kind of the return on investment, for that. So I think that that's going to be interesting. So that's part one in this study. Really excited about to see where it goes. So the other part of this is kind of what else is happening in the lipid kind of realm. So if you also look in the New England Journal at the March 28th edition, there was a study, the Easy Pave trial, that really looked about getting people at high risk an LDL below 55 versus under 70, and really showed a pretty significant difference in mortality, about a 67% mortality of that of someone who has an LDL 70. So that certainly sets the tone for what's going on. We have new guidelines from our ACC AHA brethren, who now have gone back to a number. So we should be below 70 for our high risk patients. Maybe that's going to change to 55, 100 for our other patients. Everyone should have a lipoprotein A checked once. So I think a lot of these things are going to change, and I think it's going to be kind of very interesting what we are doing going forward. So I think something that had just become kind of a shoulder shrug type thing, of course you should be on a statin, and you should be on one of these potent ones, is now going to have certainly more nuance. And I think all care should be individualized, and I think we're going to be kind of having discussions on patients on kind of adding something to their regimen that they might not be on, and then 55 might be the new 70. Our next article is from Diabetes CARE, and it looked at estimated optimal individualized diabetes risk prediction from preventive interventions in the U.S. general population. So the design of the study was to calculate a 3-year predicted risk for diabetes with a model that included individualized preventive intervention effects for metformin therapy and intensive lifestyle among U.S. adults with prediabetes. So the study looked at over 2,700 participants who had prediabetes from the NHANES trial between 2015 and 2020. The researchers used a validated type 2 diabetes risk prediction model, and they calculated predicted risk and summarized the optimal prevention studies. So which of these would be best for which individual patient? The mean predicted risk in the sample was 18.4% for standard lifestyle recommendations, which would be the placebo group, 14.4% for metformin, 8% for intensive lifestyle, and 7.6% for participants' respective optimal intervention. The optimal intervention strategy was intensive lifestyle for 91% of the patients. Neil?
John, ordinarily I would say I love this trial because I'm a believer in lifestyle interventions. And you and I have talked so many times about that granddaddy of preventive trials, Diabetes Preventive Program Trial, DPPT, New England Journal, 2002. There's no doubt that it's a good idea to have an intensive lifestyle program and that it works. In that study, twice as good as metformin to decrease progression from pre-diabetes to diabetes. And this trial said, what if we looked at that at the population at large? And, 90% of the people did better with lifestyle. That's as expected. And potentially that could decrease 12 million people in the United States over 3 years from progressing to diabetes from pre-diabetes. But that's no longer the world that we solely live in. We have all of these other powerful medicines that we choose from now when we see people who have obesity and prediabetes. And we talked about a couple of years ago already on our podcast, the trial of tirzepatide for obesity treatment and diabetes prevention. And what they did there, to remind our listeners, in the SURMOUNT trial, which was the large trial of tirzepatide for obesity, they looked at the people who also had prediabetes and they continued following them on medicine versus placebo for a total of 176 weeks. The results were really phenomenal. Tirzepatide versus placebo in terms of progression from prediabetes to diabetes, 1.3% versus 13.5%. That is a 93% decrease in progression to diabetes from prediabetes in people with obesity, obviously statistically very significant. Really, the world we live in now is one when someone is at high risk and they have prediabetes, particularly if they also have obesity. We really are thinking, as we should, very strongly about GLP-1s, which have, in this case, the dual agonists that we mentioned, that have, really good evidence of decrease in progression. And we live in a world of ands. And lifestyle modification, because we feel healthier and we do better when we treat both with a medicine, in this case, to decrease progression, and diet that is healthy and sufficient exercise. Our next article from Diabetes Care is on the impact of metabolic bariatric surgery on weight loss and glycemic control in adults with type 1 diabetes. This was a multi-center retrospective cohort study. The goals were to see the effect of bariatric surgery in people with type 1 diabetes and obesity. This was a retrospective study of 162 people living with type 1 and obesity 1 year after surgery. The mean total weight loss percentage was 29.7%. Insulin requirements dropped from 0.75 units per kilo per day to 0.32, so more than halved units per kilo per day. And A1C went from 8% to 7.6%. LDL, HDL, total cholesterol, and triglyceride levels significantly improved as well, all significantly. John?
Neil, some of the questions of this particular study wouldn't necessarily be weight loss, right? So if you did a bariatric procedure on someone who's overweight, you would expect, 3/4 of them would lose a significant amount of their excess weight with having a bariatric procedure. I think the big question is someone's insulin requirement. And if someone is completely insulin dependent, are you going to see that decrease in insulin requirement? And you certainly do in this. So people will be able to achieve the same glycemic control with a lot less insulin. I think one of the caveats of this is something that I kind of found looking back in the research. And when they've looked at research on people who had type 1 diabetes who had a bariatric procedure, 15% of them had ketoacidosis in this one study in the postoperative period. But I think the one takeaway points is we should have a little bit more trepidation in the perioperative space for someone who's going to have a bariatric surgery who has type 1 diabetes, with that caveat, and certainly something that can be kept an eye on and prevented. And remember, the big takeaway point, and I've seen residents make this mistake over the years, everyone with type 1 diabetes needs some insulin every day. So you don't really truly make someone who's NPO, you don't give them zero amount of insulin that day. So people are going to need some. So I think there's going to be some nuance in the perioperative period, but otherwise this paper follows along with what we would expect. Our next article is from the New England Journal of Medicine, and it looked at Finerenone in type 1 diabetes and chronic kidney disease. So the researchers conducted a phase 3 trial involving adults who had type 1 diabetes, CKD with a GFR somewhere between 25 to 90, and albuminuria somewhere in the 200 to less than 5,000 range. The patients were already receiving an ACE or an ARB. Patients were randomly assigned to receive Finerenone 10 or 20 milligrams per day, depending on what the GFR was, or a matching placebo. The primary outcome was a relative change in the urinary albumin to creatinine ratio of a period of over 6 months. So a total of 242 participants underwent randomization. The mean urinary albumin to creatinine ratio decreased from 574 at baseline to 373 at 6 months among all the participants assigned to receive Finerenone, and from 506 to 475 among those who were assigned to receive placebo. Over a period of 6 months, the albumin creatinine ratio decreased by 34% with Finerenone and 12% with placebo. That corresponded to a 25% greater reduction with Finerenone than placebo. The most common adverse events was hyperkalemia, which happened in 12 participants, were 10.3% of the patients with Finerenone, and 3.3% in the patients with placebo. 2 participants, or 1.7% overall, discontinued Finerenone because of this hyperkalemia. At 6 months, the change in GFR was a decrease in 5.6 mLs per minute with Finerenone and a decrease in 2.7 mLs per minute with placebo. And the GFR values approach baseline levels during the washout period.
John, this was a much needed study and really exciting to see. So we know that the KDIGO guidelines talk about pillars of care in treatment of chronic kidney disease. And for people with type 2 diabetes, that's ACEs and ARBs, SGLT2s, Finerenone, and GLP-1s. And they all work through different mechanisms. Chronic kidney disease is also a big deal for people with type 1 diabetes, but there's only been one pillar of care available to that group, ACEs and ARBs. And, SGLT2s, while sometimes used off-label, carry with them a significant increase in the risk of euglycemic DKA, which we've talked about before here. So there's been a real need for treatment for people with CKD and type 1. And Finerenone now has evidence to support its use as a nonsteroidal MRA. It is one of those pillars that with the amount of decrease in albuminuria that we saw here, one expects that will likely also lead, and hopefully there'll be other studies to show that leads to a slowing in the progression of eGFR decline. Now, I just want to touch on one other thing that you said, and that was that the change in EGFR was greater over 6 months, negative 5.6, with Finerenone than it was with placebo, negative 2.7. And it's important for our audience to understand that this is not a negative effect of Finerenone. This is what we see when we begin ACEs or ARBs or SGLT2s. You and I have talked a lot about this EGFR dip that is not due to nephron damage, but rather due to a hemodynamic effect when you decrease hyperfiltration that often people with chronic kidney disease have. So when people are followed out further, and we see this really dramatically when you look at those graphs of ACEs and ARBs and SGLT2s, as well as type 2 diabetes with Finerenone. When you follow the graphs out, we see this initial, what's called the EGFR dip, and then a return, and then eventually improved EGFRs on treatment drug compared to placebo. So in summary, I think this is an exciting advance that is much needed for people with type 1 diabetes. John, our final article for this month from Diabetes Care is the effect of SGLT2 use on mortality, amputation, and healing in people with diabetic foot ulcers. We know that diabetic foot ulcers are the leading cause of non-traumatic lower limb amputation. The impact of SGLT2 use, though, on lower limb amputation has been debated. There was some concern in initial studies, or in one of these studies on canagliflozin, that was not seen in other studies. The aim of this study was to determine specifically in patients with diabetic foot ulcers if the use of SGLT2s would influence amputation and wound healing. This was a retrospective study conducted in a French specialized diabetic foot center. All patients treated for new diabetic foot ulcers between January 2022 and May 24, and who had at least a year follow-up were included. The primary endpoint was 1-year amputation rate. There were 452 patients in the study. 94 were treated with an SGLT2 inhibitor. 358 were not. The mean age was 70 years. 77% of the patients were men. In the adjusted statistical model, there was no significant association between the 1-year amputation rate and SGLT2 use. The 6-month healing rate was not significantly different between patients treated or not treated with SGLT2 inhibitors, 54% versus 44%. Healing time was significantly less in people treated with SGLT2s, with a mean difference of 44 days. That's from 136 days versus 181 days. And the 1-year mortality rate was significantly lower in the SGLT2 inhibitor group, 1.1% versus 9.2%, with a p-value of 0.009. John?
So Neil, I think that, an interesting article that doesn't completely kind of blaze new trails, because I think the people in the know would say that there really is not this association. But for me, I think it kind of strikes a couple different things. So, study on canagliflozin early on said maybe it's associated with an increased amputation rate, right? And that kind of has been carried a little bit as a scarlet letter through many years now, and people can't completely get away from this. Correlation is not causation. So two things that often happen in the same space, right? So our patients with diabetes are much more likely to have peripheral vascular disease that leads to bad complications, right? And just because someone might be taking an SGLT2, so what's the harm of just avoiding those medicines in people with peripheral vascular disease. We spend an awful lot of time talking about all the benefits of SGLT2s that really are not their glycemic benefits. SGLT2s very much are the lipid lowering agents of the 90s, right? So they help in so many different areas in our patients with diabetes, and it would be really harmful to exclude patients. People with peripheral vascular disease die of MACE, right? So I think instead of kind of chasing this ghost that doesn't really exist for the SGLT2, maybe we should turn our peripheral arterial disease attention to that fact.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
and keep learning.